Today's topic is growing older with cancer. What changes and what does not? We have three Moffitt experts from our senior adult oncology program here today to answer all of your questions and share the latest on this topic. Joining me are Dr. Martine Eksterman, program leader in the senior adult oncology program, as well as Dr. Christine Sam, assistant member in the Department of Individualized Cancer Management, and Dr. Anna Gomes, a molecular oncologist here at Moffitt. Thank you all so much for being here today. And before we get underway, just a few quick reminders for our audience. Please submit your questions in the comments section and we'll do our best to get to as many as possible. And please keep in mind, we cannot offer personal medical advice or make a diagnosis via Facebook. Additionally, Facebook is a public forum, and any comments or questions asked here are visible to the public. Again, thank you all for joining us. Our first question here today, Dr. Eksterman, I'll ask you, why is it so important to have services geared towards the senior population?
Well, the first thing is that half of the cancers happen beyond the age of 70. So really, aging is linked with an increased risk of cancer. And once you have a cancer in your 70s, not everybody is the same in their 70s or 80s or 90s. We see increasingly patients in their 90s. Some people can be 90 and fly into space, but most patients who are 90 years old probably cannot do that. So you have to individualize the treatment, and we want to do precision oncology. So we want not only to be precise in targeting the cancer, we want also to give to each patient precisely what they deserve as the best treatment for them. And so this is why it's important to evaluate also the patient side and why we have a senior adult oncology program.
And I'll ask you a quick follow-up. How many of Moffitt's patient population falls under that senior category?
Well, I would say about a third of Moffitt patients are 70 and older. So that means there is a little referral gap, okay? But so it's obviously not going to be every single patient see in our senior program. And we are doing geriatric screening when Moffitt patients go at Moffitt. We have a little senior adult with quick geriatric questions that we can do for new patients. And that has also determine, who is best followed by our program, who can be followed in other settings. And we work with the disease-specific programs to figure out which are the patients who benefit. The specificity of our program is we have a multidisciplinary team approach. So our patients, if needed, we have the dietitian, the pharmacist, the nurses, the social worker with a know-how of treating these older patients, and we work together as a team. And this multidisciplinary team, it has been shown you decrease the bad side effect from the treatment by 20% if you do that, and you improve the chances of completing your treatment correctly. That's the strength of the team. It's that multidisciplinary approach.
Yeah, I just want to add to that. I think having that multidisciplinary team, it kind of helps anticipate problems before they happen. We know that in older adults, they have more complications sometimes with treatments if they're more frail. And so being able to assess that up front and knowing what the limitations are helps us tailor the treatment appropriately so that we limit the amount of toxicities that patient has with their treatment by having that more personalized approach, by knowing what their limitations are.
Great answers, everyone. Thanks so much for weighing in. If you're just joining us, we have Moffitt's senior adult oncology specialist here today answering your questions about aging with cancer. So be sure to post your questions in the comments section below. Dr. Sam, I'll ask you this next one. What factors increase the risk for cancer as we age?
Yeah, there's a lot of, aging itself is the biggest risk factor for cancer. As we age, our cells grow and divide through the course of our lives, and they can develop abnormalities as time goes on. And those abnormalities are called mutations, and they can often lead to cancer. A proportion of cancers are hereditary, but a lot of patients are surprised to find out that actually the majority of cancers, especially in older adults, are not necessarily hereditary. They are just a factor of these abnormalities that can collect in these cells as we get older. Other things are also exposures as we go through our lives. So a long history of smoking, for example, or those things can affect or cause more abnormalities in our cells that can turn into cancers later on. Various other exposures in our life can also, lead to cancers in the future.
Dr. Gomes, I know you're doing a lot of exciting work in the world of tumor biology. How does the aging process affect tumor progression?
Well, just like Christine was saying, essentially, as we grow old, we are kind of like different biological entities. And I think everybody can understand that because we feel that in our daily life, right? As we grow old, we start having pains, we start having different things that we didn't have at an early age. And that is essentially caused by what aging does to our cells. And cancers, when they are growing in our body, they are not growing isolated, so they talk to everything that is in our body. And so essentially what happens is, as you grow old, things change and cancers change accordingly. So in a way, you can think of a cancer that grows in an older person almost as a different disease than when it grows in a younger person. And that is why it's so important to have, this personalized aspect of cancer treatment that accounts for all those biological changes.
Something you mentioned there leads right into my next question, and that's how does age affect the way we treat cancer? Dr. Examen, I'll let you start with that one.
So I think what is important to know is if you are a healthy older person, you can probably get most of the cancer treatments just as a younger person would have if you do a proper management. Many people may feel generally great, but have some vulnerabilities. And one of the goals of our initial screening is to detect these vulnerabilities, and as Dr. Sam said, to set up things to prevent trouble. And a good proactive management allows patients to get effective cancer treatments while preventing and managing the side effects more actively than you would in a younger person. And that's a lot of our patients could get a pretty good treatment with supportive care and some approaches. And then sometimes the full-blown treatment you would give to younger people is simply not indicated because it hasn't shown a benefit past a certain age. Like for colon cancers, sometimes it's not appropriate to give oxaliplatin in older people because it doesn't add to the benefit and it simply adds to the toxicity. So these are some of the things that change with age.
Along a similar line, Dr. Sam, I'll ask you, does age affect the way we screen for cancer? Some of the different tests might be a little uncomfortable from time to time for a younger person, let alone a senior person.
Yeah, that's a very controversial question. And so it depends on who you ask sometimes in terms of what answer you'll get. But I think when it comes to screening, the purpose of a screening test like getting a PSA or getting a mammogram, the purpose is to detect cancers early that we are able and want to treat. And so when you have each screening decision should be individualized, because when you look at the major groups, some people say, for example, stop doing breast cancer screening at X age, whether it's 65 or 75, and many patients at 75 will say, hey, I feel great, and maybe even their life expectancy could be another 20 years. And so for them, screening may be appropriate at that time because they have quite a bit of longevity yet to go based on their health status at that point. And then some patients may say, wherever they are, that they may not want to aggressively treat their cancer even if it was found. So it's really an individualized decision between the patient and their doctor, especially when they get to older age regarding screening. We have recommendations up to a certain point, and then the different bodies disagree on what the right age is. And that's because there is no right age. Really, it should be a good discussion between the patient and the doctor about what their goals are, and what their desire is for finding cancers early. If we're going to be able to treat that effectively based on where they are in their health situation.
I think that's the right point to include a comment about what we call life expectancy. We kind of in the public, we all know life expectancy at birth in the US is around 80 years old, late 70s, something like that. But that's the life expectancy at birth. When you are, let's say, 75, well, you didn't die in a car accident as a young adult. You didn't die of a heart attack when you were 50. You did. So you are a survivor. So your life expectancy is actually longer than the life expectancy at birth. And if you take all the persons in the US who are 75, the life expectancy is 12 to 15 years. All right. And an 80-year-old person in the US has 40% chances of reaching the age of 90. And often our patients don't realize that. So for screening, usually we think if a person has more than 10 years in front of them, it's probably worth continuing screening.
And we've got our first viewer question coming in from Facebook viewer Edward. He asks, how well are senior adults being included in clinical trials? Dr. Sam, I'll give you that one.
Sure. That's a great point, and it's something that we are trying to improve. Historically, it hasn't been great. It hasn't reflected the amount of the population of older patients that we have in clinical trials. Clinical trials doesn't necessarily reflect the population of older cancer patients in society. And it's kind of affects really how we treat patients, because we don't know if the treatments in the clinical trials will have the same amount of toxicity and efficacy in our older patients. And so it really, there's a great push, I think, in this country and really at Moffitt too, to include more older patients in trials. And part of that is assessing patients correctly and saying, hey, this is a very fit patient, and really supporting the use of clinical trials in older adults. So really there is a recognition that we have we've had fewer patients in clinical trials that are older than we should, and we need to really increase that. So there really is a push for that right now.
Thank you for answering that one, Dr. Sam. And thank you, Ed. Great question. If you're just joining us, we have Moffitt's senior adult oncology specialist here today answering your questions about aging with cancer. So be sure to keep the great questions coming in the comments section below. Dr. Gomes, I know we started to get a little bit into tumor biology earlier. Sort of along those lines, as we age, do we become more resistant to cancer therapies?
Well, that is highly dependent on the type of cancer that we're talking about. But as a whole, I think it is now in the field kind of established that you do, in fact, get a little bit resistant to some therapies, especially chemotherapies and radiotherapies. And that is derived from the fact that as we grow old, we have a lot of stress responses in our body. And they accumulate, and those stress responses in general protect cells against death, which is a bit problematic. On the other hand, you have now a lot of immune therapies that are also used to treat patients. And in that case, we are actually not very sure about how aging affects immunotherapies, mostly because there has been a lack of information for us to actually properly assess that, with this idea that as we grow old, our immune system doesn't work so well. So for a long time, patients that were older were not quite put on immunotherapies. But it seems now that there is a lot of information coming out suggesting that potentially immunotherapies might be good for older people. So it really depends on the kind of therapy, the kind of cancer. And again, that is why it's so great to be able to have a senior adult program that can tailor everything to your own biology.
Fantastic. Thank you, Dr. Gomes. Another question here from our audience is, what factors should doctors also consider besides just your chronological age when it comes to treatment options? Dr. Extraman, I'll let you start with that one.
Sure. Yeah, age is just a number. I I sure believe that. So one of the things that we look at is how functional people are, and we can look at it at different ways. We can do a little questionnaire with, which activities are you able to do? And in our clinic, we do also a short test we call the time up and go. It's very simple. You raise from a chair, you walk 3 meters, you do a half turn, you come back to your chair. And that gives us an idea of how fast you walk, how mobile you are. And there are some interesting data. If you walk 4 meters, and the speed at which you walk, that's directly related to how long you have to live. So the faster you walk, the less likely you are to die in the near future. So there are other things. We look at the nutrition of our patients. And we are doing research trying to see if we can correct nutrition issues. And sometimes nutrition issue may have surprising things that happen. People may simply have a denture that doesn't fit. And so, you fix that, people eat much better, regain weight. I've seen some impressive weight regains by fixing simple things like that. And if you can, you can also assess we assess carefully which support people have. Okay, in Florida, something that happens sometimes is we have snowbirds who are here and all their families up north. Well, if they have a health problem, that's a problem because the children, not necessarily here to help. So sometimes they just count on their neighbors. And I have to say, RV communities often have very good neighbors that help each other. And sometimes the main caregiver is a neighbor. So that's also important to assess. And that's part of all of our frontline approach. Figure out where are the potential problems and how can we tailor the treatment so that we avoid the problems.
You mentioned food briefly a little bit in that last response, and our next audience question actually has a little bit to do with that topic. Viewer Carrie asks, what is Moffitt doing to educate patients about eating a vegan diet with high content of cruciferous vegetables and raw, or at least adding a high amount of cruciferous vegetables to their diets?
Okay, so Moffitt dietitians have a pretty complex program, and they have one of them is the SOAR program. Now, right now, it's limited to cancer survivors because it's a capacity issue. So they decided to focus first on cancer survivors, and the SOAR program is focused on healthy living. And indeed, they may not necessarily recommend a strict vegan diet, but they definitely recommend healthy recipes, less meat, more exercise, and things like that. So it's a more comprehensive approach than just diet for that one. Our dietitians are familiar with vegan diets, and we have patients who, when they are vegan, they know how to counsel them to maintain their nutrition intake and know what to do when they are on cancer treatment.
On that topic of diet and exercise, Dr. Gomes, I'll ask you this. How can those two things affect our tumor biology?
Well, they can affect quite substantially. In fact, there is a lot of evidence coming up and established for a very long time that, for example, caloric restriction is it's something that has it has longevity effects, and so people can live longer, healthier. And there is now research that has also shown that it also sensitizes people for chemotherapies and other anti-cancer therapies. Exercise, it's funny that you mentioned because, research is always evolving and every day we learn new things. And very recently, I believe as recently as on Friday, we have actually some data that came out in the world that shows that exercise actually protects against cancer progression into metastatic disease. So, while all those things really need to be carefully thought and discussed with your doctor, there is definitely some room for improving the chances of getting treated with lifestyle alterations. But with this said, I just want to caution everyone, because, you know, just going ahead and making all these modifications in your diet and your lifestyle can actually also have detrimental effects. So it's incredibly important to do these well monitored by your team of doctors.
I want to echo that point by Dr. Gomes, just because I think there's a lot of things out there. You know, there's a lot of books out there and a lot of contradictory things you might read about what diet is helpful for cancer. You should do this thing or that thing. And some of those things are not always as well studied as you might think. And so I think it's always important before kind of following a specific diet plan to talk with, you know, your doctor, your oncologist, to know what would be the most recommended way for your body to really function going forward. You know, there's not a specific diet that generally we recommend, but we do talk about like a plant-based type of diet, although not necessarily a strict vegan diet for cancer, the best type of healthy thing for you. But yeah, definitely before following a specific diet, highly recommend talking with your oncologist or doctor to make sure it's the right plan for you.
Yeah, and I think it's important indeed to have individualized counseling, because some patients may need a high protein diet if they have lost a lot of weight for their cancers and need to rebuild muscles and things like that. So these are various individualized treatments. Sometimes you simply need a supplement because you have a difficulty swallowing and things like that. Other times, indeed, rebalancing your diet might be very helpful. A question I get a lot is my patients ask if they should go on a sugar-free diet because on PET scan, the cancer takes on a lot of sugar. And the answer to that is, if you are not diabetic, your body is very good at regulating the amount of sugar, because the main organ in the body that eats sugar is the brain. Okay, the brain eats 20% of the body's sugar, and much more than any cancer, by the way. So the body maintains a very steady level. So if you don't have diabetes, I mean, don't stuff yourself with pastries, but you can eat a reasonable amount of sugar.
Thank you all so much for weighing on that one. Great question, Carrie. Those of you in our audience, please keep the questions coming. Our next viewer question asks, do you recommend that older adults with cancer get the new COVID booster? And Dr. Eksterman, I'll let you start with that one.
All right. So that's the new Omicron booster. I would say yes. It's safe in our cancer patients. We did actually a study at Moffitt in the patients who did get the original COVID vaccines. And we looked at both patients with solid tumors and patients with hematologic malignancies. And the patients with solid tumor get a good response. It's not quite 100% of the level of response you would have in somebody who doesn't have cancer, but it works. So we do recommend the COVID vaccines. And yes, the new COVID booster protects better against Omicron than the previous vaccine. So I would recommend it when it comes out. It should come out towards the end of the month. And for the patients with hematologic malignancies, sometimes either their blood disease or their treatments can knock down their response to a vaccine pretty deeply. So for these patients, there are some antibodies that can be given to help prevent severe complications from a COVID infection. So that's to be discussed individually with your oncologist, hematologist, if you have a heme malignancies. For the rest, patients with solid tumors, even if they're on chemo, can mount some response to a normal vaccine.
While we're on that topic, flu season right around the corner. What should our senior population know about getting the flu vaccine? Dr. Sam, I'll let you take that one.
We definitely recommend it. Absolutely recommend it. And the CDC says it is safe to give, both around the same time in terms of the COVID booster and the flu vaccine. So, flu actually has many patients who succumb to that, and you could have complications from the flu itself. And so having the flu vaccine helps protect from some of those complications that you might be make it harder to tolerate treatment, or it might put you in the hospital and delay treatment. And so we want to make sure our patients are as healthy as possible. So we highly recommend the flu shot as well.
Is there any difference in this population when it comes to live virus vaccines versus something like an mRNA vaccine?
So live virus vaccines are often not recommended in cancer patients on active treatment because they are immunosuppressed. So you have, for example, to be careful. If you get a shingles vaccine, there are two types of shingle vaccines. Some of them are live virus, and you should not give them to a cancer patient. Another one called Shingrix is a molecular vaccine, so it's not a live vaccine, and this one can be safely given to cancer patients. The only difference is you need 2 injections instead of 1.
I appreciate you tackling that one, Dr. Eksterman. If you're just joining us, we have Moffitt's senior adult oncology specialist here today, answering your questions about aging with cancer. So be sure to post your questions in the comments section below. Switching the focus a little bit from the patient is, what do caregivers need to know about helping their senior loved ones living with cancer? Dr. Sam, I'll let you take that one.
Yeah, that's such an important piece of our care, is involving the caregiver in the care. Just like Dr. Eksterman was saying before, we look at the patient's social situation. Sometimes they are in a situation where the family's far away, and that's something we call social frailty if they don't have, a lot of support nearby them. So we very much try to involve the patient's caregiver in their care so that they feel like they're an active part, that they know what's going on, that they can be an advocate for their loved one, and also help provide the resources they need. So part of our assessment is figuring out what the patient needs, and then how the caregiver could fit in terms of helping the patient. And then also caregivers go through a lot of caregiver fatigue, and sometimes needs some respite care themselves. So our social work team kind of helps sort through some of those issues that can arise, and really help navigate how to care for our patient as a team, and really support the caregiver in providing the best care for the patient. We have some wonderful nurses on our team that are very responsive to patient questions and concerns. So we always, tell our caregivers to always call if there's any concerns, because usually a very responsive team.
Along a similar note, next week is Fall Prevention Awareness Week. Obviously something that impacts this population tremendously. Dr. Eksterman, what are some tips that we can give our viewers on just how to prevent falls in that population?
So it's true, okay? A person who gets chemotherapy, an older person who gets chemotherapy, has 40% chances of falling during their treatment. And it's interesting to know, it's not necessarily that you are anemic or tired, because everybody's anemic or tired. I may contribute. But if you have muscle weakness, or if you have some confusion because of a medication you are getting for your cancer, that's a risk factor for a fall. So also some chemotherapies can give you neuropathy. So it can numb your finger and toes so you don't feel the ground as well. So that means at night, for example, you should have a light on to prevent you from falling, so that you can see the ground, because you would not feel your carpet as well as you would normally. There are also, we have a balance clinic. So if you are starting to feel that maybe a bit unsteady with that neuropathy, we can use that balance clinic to advise you what's the best exercises to do, which device you may need to help you, tips and tricks to avoid falling. That's something that we try to be very careful advising our patients about. Another thing that's a risk for fall is dehydration. And when we age, we don't get thirsty as fast as a young adolescent. And we get much more dehydrated by the time we get thirsty. So we have to remember to drink really on a regular basis, even if we are not thirsty. And then if we have diarrhea, we will get dehydrated more rapidly than a young adult. So it's important to act on that diarrhea, take Imodium, drink well, and if you can't keep up with the fluids, to contact your oncologist and make sure that you get enough fluids to prevent you from falling.
We got another question from our audience. Sarah asks, heart problems are more common as we age. What are the considerations for cardiac health prior to or during cancer treatment? And does Moffitt provide cardiac monitoring? Dr. Sam, I'll give you that one.
Yeah, so there are certain cancer treatments that absolutely can affect the heart, and not all cancer treatments can affect the heart. Some cancer treatments don't really have much of an effect on the heart, but it's important to know what the patient's medical history is so that we can tailor those treatments appropriately. Certain breast cancer medicines sometimes can affect the heart, and so if it's a specific drug that is known to have heart toxicity, we often do a little bit more cardiac monitoring while patients are on therapy with like certain tests like what something called an echogram. Sometimes patients need EKGs periodically during their care. And especially we take that into concern when they have cardiac issues at baseline. We also have a wonderful cardio-oncology team that we often refer to here. So it's one of the specialized things we have at Moffitt, that it's cardiologists that specifically specialize in cancer patients and knowing how to manage patients with cancer. So we often have patients we co-manage with the cardio-oncology team so that even if they have a treatment that may have cardiac side effects and they have a history of cardiac problems, we can maybe do it safely so that they can get the best of both worlds, try to avoid harm or do things to avoid any cardiac side effects while still being able to get their cancer treatment effectively.
Yeah, and speaking of clinical trials, we actually do have a clinical trial to prevent cardiovascular side effects from certain cancer treatments, which we call the anti-HER2 treatments that we give for breast cancer. So I happen to be the Moffitt PI for that study, principal investigator. And so people who are receiving Herceptin or similar treatment for HER2 positive breast cancer, they half of them get carvedilol, which is a cardiac protecting drug, and we hope it will protect against cardiac toxicity. So if you're interested in that, that's one option.
Sticking on the topic of heart health, Dr. Gomes, can your heart health or your cardiovascular health play a role in tumor biology?
Absolutely. I mean, the heart is what is what keeps essentially everything alive and controls blood flow. So cardiac health will intrinsically have an effect on your cancer biology.
And I'd love to give our audience a little more of a look into the research that you're doing in the Gomes lab. When it comes to lung cancer, what can you say about the work you've got going on?
So essentially, and even though in the clinic we have such personalized medicine and such great care for the elderly, in research, this is something that we haven't quite studied in detail, is how the biology of aging affects the biology of a tumor. And so my lab is hoping to fill this gap in knowledge so that we can understand what are the differences in cancer when it occurs in a younger person versus when it occurs in an older person. As I mentioned, we are just we are very different people when we are in our 20s and 30s than we are when we reach our 70s and above. And so we really need to take that into consideration in order to be able to develop medicines that are better tailored to the biology of the patient, rather than just, and account for all of that, rather than just assuming that everybody is the same and responds the same way to the treatments we have available.
Yeah, there is the big, for example, a difference as we age, we have more inflammation in our body. Okay, it's all this little damage, that kicks and creaks, and so that increases these inflammatory markers like IL-6 and cytokine, and that has an influence on cancer and how it behaves. And one of Dr. Gomez's interest is what we call metabolomics. It's like all these various molecules that circulate in our body. How does it influence the cancer growth as we age.
Thank you both for weighing in on that one. If you're just joining us, we have Moffitt's senior adult oncology specialist here today answering your questions about aging with cancer. So be sure to keep the great questions coming in the comments section below. Another question we've got here is, am I less likely for my disease to be cured at age 75 versus, say, age 40? Dr. Sam, I'll let you take that one.
Not necessarily. For example, immunotherapy, which we talked about earlier, there's a lot of data that older patients can respond just as well to immunotherapy, just like younger patients. The toxicity concerns might be slightly different, but older patients can respond to treatments just as well as younger patients in many cancers. I'd say probably in most cancers. There are some situations where if the older patient's immune system might not be as strong as it used to, it may not be able to fight the cancer quite as well. But in most situations, I would say that older patients can respond to treatments just as well. It's the main matter is tailoring the treatment appropriately so that we don't so we strike the balance of avoiding too much toxicity while still getting the really good efficacy of treatment. So that's the main thing that we want to do, is be able to give the treatment effectively while trying to avoid any harms to the patient. But older patients can respond just as well as younger patients to most cancer treatments, I would say.
Yeah, I think it depends indeed on the cancer. There are some cancer where age is really bad, like an acute myelogenous leukemia. As you age, the prognosis worsens, and we know that's because the leukemia is different. It comes from an earlier cell in your bone marrow, and so you have less cells to replace, and it creates a problem, and it's a challenge in treatment. But again, we have new treatment coming out that are slowly improving the prognosis of, even if the leukemia is different, we can improve the problem. Sometimes the prognosis is worse. We don't know exactly for sure. Like ovarian cancer has a worse prognosis with aging, but we don't know exactly why. And we have a big research project going on at Moffitt to understand that and say, okay, what's different in the biology or the treatment of these patients that makes that, yeah, the ovarian cancer is not doing as well in older women than younger women. And we sure hope we'll correct that once we understand what's happening. It may be in the lab, like Dr. Gomez's lab, or it may be in the clinic, like our clinic, that will find a solution. But we are working on it.
I know we talked a lot about our older population. Our viewers want to know, what age are patients considered older or part of the geriatric population? Dr. Sam, I'll let you take that one.
Yeah, so in our senior adult clinic, we typically, since we have to have an age cutoff, we typically have patients that are about 70 and above. But just like we were mentioning before, age is a number. When we decide on treatment, it's not based on chronological age, it's more based on functional age. And based on that evaluation, that comprehensive evaluation we do of patients in terms of how we think they are physically, in terms of their ability to handle their treatment. So it's not so much on their age, but on their physical ability. But in terms of kind of the age cutoff, since we have to have an age cutoff in our senior adult clinic, we can't see everybody. We typically go with 70 and above.
Got another audience question here, Dr. Eksterman. I'll give this one to you. How do we help older patients achieve the best quality of life?
That's a great question, because for many people, yeah, they want to live long, but they sure don't want to be dependent. They sure don't want to feel bad. And remaining independent is often a very strong concern about my patients. So interestingly enough, chemotherapy can be the best way to achieve a good quality of life. In lung cancer, for example, and if you give chemotherapy, patients have a better quality of life than if you just give supportive care. But it may not always be the case. Sometimes if I have some very frail woman with a breast cancer that is estrogen receptor positive, it's just a small tumor, and we may just give hormonal therapy instead of doing surgery, because the idea is just to calm the cancer and not submit this very frail patient to a surgery and an anesthesia with the risk of delirium and things. And there are some data that came recently at ASCO that if you do that, We have about 85% of these women who don't have a progression after 5 years. So it can be a helpful alternative when somebody doesn't do surgery. So we have to really evaluate with each patient their goals of care when we get started with treatment. We like to ask what matters most. And it varies a lot. Some patients say, hey, my mother died at 105. I want to beat her. And other patients are telling me, I'm the caregiver of my husband with Alzheimer's. Whatever treatment I get, I want to be able to take care of him. So these are various goals that you have to elicit with the patient.
We have another viewer question. Like to know, are vitamins, supplements, and herbs safe for older cancer patients undergoing treatment? Dr. Sam, I'll let you take that one.
Yeah, so it depends. Part of what we have in our multidisciplinary clinic is a pharmacist. Some herbs and supplements are okay, or vitamins are okay and won't interact with therapies, but there are certainly some that definitely interact with treatments. And it's not with supplements and herbs, some of them are not necessarily, they're not FDA regulated like medicines are. So we can't necessarily check for interactions with their medicines with some of these things. So we always advise caution with being on a number of supplements, because we don't always know the interaction it might have with the chemotherapy, either increasing toxicity or reducing efficacy. So every time we see our new patients in our senior adult clinic, we usually ask them to have kind of their medication list so that we can go through it, look at the supplements, look at what's in the supplements, and make sure it's not something that could be potentially harmful or interact with the treatment. And so we usually will have our pharmacist look at that. And that's kind of part of that personalized management plan, looking at the medicines that the patients are on, the supplements, herbs, everything that they take, and make sure that there's nothing harmful that will affect their cancer treatment. Because some things are very safe and some things could be very harmful, especially things that you just kind of find on the internet and that don't have a lot of data behind it.
Dr. Gomes, I'll ask you, how do things like vitamins and supplements affect our tumor biology?
They can affect quite dramatically. In fact, I mean, especially in the context of an older person, where there are a lot of changes in the way we absorb nutrients and vitamins. Having all these supplements can have benefits and can also have detriments to the biology of the tumor cells. So I think what Dr. Sam was saying is incredibly important, to make sure that that everything is taken with your team of physicians and other people, because at the end, I mean, this is not a one size fits all, and there is a lot of things out there in the internet, and we hear a lot of things. But from a biological point of view, I can tell you that not everything we hear is exactly as it works. And so caution is incredibly important. With that said, there are some vitamins and some things that can produce a benefit in a specific population or type of cancer. But like I said, it's important to just make sure that you first do no harm, and you don't actually reduce your chances of getting better just because you are taking something that you don't quite know very well about.
All right, and that is all the questions we have time for today. Thank you so much to all our panelists for answering those great questions, and thank you to everyone in our audience for joining us. For more information on our Senior Adult Oncology program, please visit moffitt.org.